Recording on. Good morning, everyone. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX, and you're joining us for another community conversation, October 9th of 2023. Happy Indigenous Peoples Day. And to start, I'd like to create a safe space in this meeting. And that means that every voice will be heard and respected. And we recognize that everybody comes to this meeting with different lived experiences. And as such, we recognize the potential for harm. And we, as an organization, and everybody who is on this call are committed to healing should harm occur. And today I'm speaking from San Antonio, Texas. I'm visiting my sister here, and this is the unceded land of, according to Spanish records, of the Coahuila take on, but there are 200 tribes, bands, and clans that have been documented on this land, and that includes the Payaya, Oteca, Paguame, Jarame, Pampapa, and Borado, as well as other Aboriginal peoples such as Carrizo, Concrudo. And they continue to carry out their traditional lifeways here. So just take a minute, especially on this Indigenous Peoples Day, to acknowledge and pay our respects to the community and the original people and their past, present, and future elders. And I invite you to think about, look up, research, and honor the land that you are on, and pay your respects as well. So with that, today we're going to do a deep dive into all things COVID, or lots of things COVID. There's been a lot of news, and to guide us there, we have Dr. Dale Reisner, who is a consultant and former head of safety and quality for OBGYN safety at Swedish. That was her former job. Now she's teaching everybody about the lessons learned there, and she's our board member, and she's been very generous in preparing to do a deep dive and answer your questions. I just want to let you know that, as a reminder, this is being posted to our public website, and it will be available for all people. And so if you don't want to have your name or your image, please turn off your video. And if you have any questions, please put them in the chat. And this is a community conversation, so your questions will be part of the conversation today. And with that, I know that we don't usually do slides, but Dale really wanted to put some up. So Dale, do you want to go ahead and, do you want me to put up the slides right now?
Yeah, that'd be great if you want to do that. So, and I'll just, while you're doing that, say, welcome everybody. We have skipped talking about COVID quite a bit this year, certainly this last half of the year. And there's a lot going, just go back to that first one. There's a lot going on. So I did want to start with this picture, which is sunrise from Bell's Beach on Whidbey Island. This is part of the Salish Sea, that Saratoga Passage. And so I thought that was quite fitting for Indigenous Peoples Day. Was telling the group ahead of time that we had a small earthquake last night on the other side of the island in the middle of the sea as the nidus point. So it speaks to the living, breathing environment that we're in, and not so much about COVID, but more about the people that started here and how we need to protect this land. So you can go to the next slide. As I have done in the past, I'm going to very briefly talk about numbers, and I just mean very briefly. At the bottom of this slide is the total death rate for the US, which is 1,145,000 plus almost 146 deaths from COVID. And the majority of the deaths and the high death rates occurred earlier in the first 2 years of the pandemic. And you're going to be hearing a lot about data from those first 2 years today. And we had a bump, as you can see by these trends. So on the left is testing positivity. And there, this is wastewater, determined much of this. The dates here, you can see September 30, so it's not going into October yet. And emergency department visits bumped. We had increase in hospitalizations and increase in deaths. And over the past week, you can see that there's a trend down in everything other than deaths. And these are deaths due to COVID. So it is still something we need to be concerned about, particularly for the vulnerable. And I'm going to talk a little bit more about who's vulnerable. So if you want to pop to the next one, Robin, and thank you, Robin, for doing this. So there's a whole list of who's vulnerable, and we haven't talked so much about this whole list. I'm going to talk a teeny bit about the infection and exposure data that we do have. The racial and ethnic minority populations I've presented in the past, and we do know that their rates of significant morbidity and mortality are, double of what they should be in terms of their representation in the population. But we also have people who are living in rural or more frontier areas who don't have access. They may not have the electronic access. They may not have some of the medication access and clinics and providers. Homeless population, our frontline workers who were hit very hard because they were the ones that were out circulating in the first 2 years. People with disabilities, this is again a group that we don't talk about too much. I had the great honor of being able to do initial vaccinations with a deaf population that was brought in by members of their community, and it just showed the collaboration that where you need to involve the people that they trust in order to reach out to many of these groups. People with substance use disorders, that became an even worse problem during the pandemic. And on top of all of that, fentanyl emerged as the leading killer. And it is a devastating drug. So we've seen young adults and teenagers who weren't in the habit of using drugs, but did a first try and had the bad luck of having something with fentanyl and didn't make it through. And so some of the work that we look at with population health does take in this group of people with a medical disorder and who have had lives that most of us attending this meeting can't relate to. Some of you may have been raised in situations that many of these people were raised in. And so that compassion that we want for these groups that are marginalized, and also our ways of getting around, how do we work to get a better approach for some of these groups is really important. And then obviously incarcerated has limitations for the access they have and how they're treated, as well as people who are not US born, particularly do not speak English as their first language. So I want to talk a little bit about the the racial and ethnic minority data piece. One of the chief issues that we've seen with the data is when you look at the Native American Alaska Native data, and I'm going to call that out because of Indigenous Peoples Day, they have at least a doubling of the risks from COVID. And one of the concerns is that they do not feel that they own their own data, and they do not feel that the data is fully representative of who they are, and for good reason, because much of the race and ethnicity data is determined by either self-report or in some places by what the clerk who registers you when you come into the emergency department or get admitted thinks you are and puts down on a piece of paper. And each state and each hospital or hospital system may do it differently. We should be looking at self-determined. And yes, that won't be entirely perfect either, but it's very easy for people to be miscategorized when someone else is determining what they think that person's background is. The whiter you look, irrespective of what your background is, whether you may have one white parent and one Black parent, or you may have one Native parent and one other parent, and you could look quite Caucasian. And so it is not okay for me or anybody else to say, you look like you're white, so we're going to call you that. The hard part of this is that the people who look more Caucasian have better health outcomes, irrespective of what their tribal beliefs are, or where their ancestors came from, or whether their ancestors lived through slavery. So it's helpful for us as people who work as advocates to remember this, that we can't judge a book by its cover, and that we need to be sensitive to where people come from and figure out ways, particularly the tribal folks now within the state of Washington, for sure, and many other places that I'm aware of, are working with and collaboratively with the data people, trying to get clean data, and also to get rid of this statement, oh, well, the numbers are too small to be statistically significant. Because if you lost a loved one, doesn't matter if the numbers are statistically significant. And we know by collective gathering of data over many years that the numbers we've been seeing are representative of a significant increase in adverse outcomes for some of these populations. So I'll move to the next slide, but I did want to put that in context of what today is honoring. So here is the numbers, and you can just see towards the far right, non-Hispanic, Native, Hawaiian, or Pacific Islander looks like no difference. But I would certainly from the maternal mortality side say we don't have enough information to say that because of the identification piece. And then look at the non-Hispanic American Indian or Alaska Native, that looks a little higher than their percentage. The unweighted share of the U.S. population is in that dark navy color. However, by all smaller studies, it's at least double. It doesn't quite look double in this data. So this is 2023 data. And it's looking at COVID deaths, not cases. And it shows you, certainly we've had more Caucasian deaths than we had.
Sorry.
Going backwards.
Sorry.
We've had more deaths in the Caucasian population, mostly attributed to the elderly. But you can see that it does in the populations where we have a larger percentage of particularly Hispanic and Black, those numbers are fairly solid. But once you start getting someone who says they have mixed ethnic background, then the data gets very muddy. So go ahead to the next one. I'm going to skip away from the data piece, and I don't know if there's any questions, or Robin, if you have any comments that you want to make before we jump into vaccines.
I think go ahead and jump into vaccines.
Super. Yeah.
Mm-hmm.
So this was interesting to me. We mostly focus on what happens in the US, but 50% of the world was fully vaccinated at the end of 2021. Within the US, those numbers were about 65% with full vaccination, and 80-some% with at least one jab from COVID vaccine. And then when you look at what we've done with vaccinations over the last 3 years now, almost, what we've seen is that research really supports the way the vaccines were rolled out in the first place, with boosters trying to catch up with the very rapid changes in the variants. But now what we're looking at is that we'll be seeing an annual vaccine that looks back, just like we did with flu, looks back over the types of variants that we've seen over the past year. And the Novavax that has been approved by the FDA does do that. So it has a target for picking up the latest variants, but it also covers, and there's some misinformation about this, it covers all the historical variants as well, even though the original ones we think are not probably even in circulation. But you never know with this virus that has mutations really quickly, whether it will step back. So it's got the historical, it's got the up-to-date.
Step back in terms of what the previous variants, the original wild type?
Yes.
Okay.
So we have the original wild virus, the initial ones that were out that were being called the Chinese variant or the Mediterranean variant. And then we hit the major flip was Delta, which was devastating. And then we moved pretty quickly from Delta. Delta was about June through September of 2021, and we moved pretty quickly into the Omicron variants. And right now, all of the recent variants have been Omicron. This vaccine should cover all of those. Don't consider it to be a booster. It's our annual COVID vaccination that would be recommended for pretty much anybody age 12 and over.
And so if there are any people that are first time getting this vaccination, that's like a very positive thing to just have the one.
Yes, exactly.
Mm-hmm.
We are expecting, if we go by last year's trends, that influenza, respiratory syncytial virus, and COVID will increase over the next few months. It looked like it really took off in November last year, and we've not seen a lot of flu cases yet. And then last year we had RSV in the summer, which was not a problem so much this year. So the respiratory syncytial virus used to really only be a concern for children, but we saw last year significant impact on elderly and immunosuppressed. So that vaccine is out. I just want to remind everybody that the primary goals for most vaccines, for really almost every vaccine, there's a few that are just prevention, but are to decrease severe disease requiring hospitalization or decrease death from the disease.
So can I ask you a question? Because Ray Dresen, thanks for the question in the chat, just asked the difference between Moderna and Pfizer. And I had a really interesting experience. I mentioned to you that I'd gotten my COVID vaccine 3 weeks ago when I was in California. And it was the first time I had ever had Pfizer. And I had previously always had like really bad side effects for Moderna, like 102 fever each time, never got any better. And the pharmacist there said that that was because Moderna had like more or greater amount or something. And interestingly, it felt very different with Pfizer, did not have the same side effects and or the same response. So I am very curious about this question that Ray asks about the differences between Moderna and Pfizer and if there are big differences.
There aren't big differences. And when I say that, the differences are really, they're monovalent, right? So we have and then we went to the bivalent. So what we see with them is some minor differences in the molecular structure, but when it comes to clinical outcomes, the clinical outcomes we care about, prevention against severe disease requiring hospitalization or intensive care unit admission, and decreases in death from COVID, they are quite equivalent. So you talk to a variety of people. Some people had more problems with the Pfizer and less with the Moderna. And remember, at one point, the FDA was saying it's fine for you to switch companies, which some people did and some people didn't. And so we were not seeing, whatever the individual experiences with one or the other is probably an individual response to that vaccination. There are certain things you can expect from some vaccines. For instance, Shingrix, you can expect to have
That's the shingle vaccine.
Shingle vaccine, that's the newer one. You can expect to have a lot of pain and potentially some other, side effects that are more pronounced than what we get with normal. But all of the vaccines that are out right now are anticipated to have the usual types of side effects that we've experienced in the past. So I don't have data on this, but I just personally got my flu shot and was going to have the flu and the RSV at the same time. And the pharmacy said we're not doing that because there've been reports for increased side effects by doing those two together. You can definitely have your flu and your COVID together without having additional adverse outcomes. You can choose to do them separately or do them together, but it's the RSV that they're trying to not pair, certainly with the flu. And I don't know that anybody's had any experience with that with COVID, because the COVID vaccines aren't available absolutely everywhere yet. And I'll talk about that in a little bit.
So there's some back and forth in the chat. We're trying to understand the difference between the vaccine and the booster. And Chris has put in there that the monovalent RNA of Moderna has 50 micrograms, where Pfizer has 30 micrograms. So can we take a step back here and just say, what is the difference between the vaccine and the booster? And if somebody has had all their shots up until now, how important is it to get the vaccine? Do you have certain protection? Is there a big difference?
Yeah. So the vaccines, again, the amount in any given vaccine is dependent on that formulation. And what we've seen clinically is not a difference in protection. So whether that higher dose in the Moderna makes a difference for outcomes, hard for me to say. When you look at adverse outcomes, excuse me, with all of the V-Safe tracking that was done by the CDC originally, both vaccinations, both monovalent, the Pfizer and the Moderna that first came out, had very similar complaints and percentages of complaints. So again, I don't know that there's a statistical difference in the adverse side effects that are not an allergy, but side effects. The boosters were needed as the virus moved into the Omicron stage, and the two monovalent vaccines were not covering as well as they needed to. The boosters came about because of that. We don't need boosters anymore. So if you never got boosted, but you had a full set of Pfizer or Moderna, then you just get this year's COVID shot.
And is that because
this year's COVID shot is not a booster? It's the vaccination for COVID for 2023.
And is the booster because the original was monovalent and now we have bivalent?
The booster,
maybe you should walk back and just explain the difference between monovalent and bivalent, because that might be of interest.
So the boots, I don't want to spend too much time on the chemical nature of it, but yes, the boosters were bivalent, which was necessary to cover the Omicron variants that were coming at us rapid fire. The monovalent covered the original wild virus and Delta quite well. once Omicron hit, we were seeing a fall off in prevention and also, more hospitalizations and so on. And so both companies that created, so they're, the boosters were either Pfizer or Moderna, but they were bivalent. So now the shot that's available is not to be considered a booster. It's a fully functional vaccination for 2023 for COVID that covers the variants that we've seen to date, all of the Omicron variants and the originals as well. So if you never got boosted, that's fine. Get this vaccination. If you never got vaccinated, that's fine. Get this vaccination. And if you had everything like I did, including 2 boosters, I will get this vaccination. It's not a booster. Yeah. Mm-hmm. So it's the same as flu, right? So we don't boost for flu typically. We haven't had to. And the flu vaccine for this year is newly composed of different components of past years' influenza viruses to try to cover what we expect is going to show up this year. And so it's, it won't be perfect and always remember for you, for your family, for your clients, no vaccine will be perfect prevention for the disease. For the flu, you may get the flu. Some of them are more efficacious, so they may have better protection against getting sick in the first place, but their goal is to prevent severe disease and death. And so all of these current ones are like that. And Anne has one more question. And then
about
I do want
whether or not, if you get COVID and flu vaccine together or separately.
Yes, they have the same efficacy if you get them together. Yeah. And then the one thing I will mention, so Robin, you can move to the next slide if you want. Okay. The one thing I will mention is if you're worried about adverse effects of the vaccination itself, do not pre-medicate. So do not take Tylenol or ibuprofen before you get the injection. You can do it afterwards. So, get the injection, get it in your system. And then if you want to be on top of some, you can do it afterwards. But there have been concerns about people who were trying to be proactive and take, and non-steroidal or Tylenol before they got their injection. And the recommendation is strongly to wait until the injection's been given. And then you can do it, a couple hours later.
So we have that was very important information. We have 2 kind of related questions. I think people are getting stuck on the language around booster. So could you clarify if the booster last year was bivalent?
Yes.
It was bivalent.
It was bivalent.
And the difference between a booster and the vaccination, that language, like Ray wants to know, what is a booster? What does that mean? I think it means it boosted the original.
The booster was an additive, basically. So we had you covered with part of what you got before. Now we're going to cover you with a little bit more. That's probably the easiest language to use. Chris, you've got some comments in the chat box. Do you have a quick comment? Because I don't want to spend too much time on this. We want to talk about long COVID as well.
I was just answering someone else's question about mRNA vaccines and how they don't mess with people's genetic material. So I was trying to keep that out of this and keep you going. So sorry.
So we do want to get to long COVID.
I was just trying to answer some other questions while you talked about some of the other stuff, and that's all I'm trying to do. So
okay, thank you, Chris, for doing that. All righty. Okay, so here's the current CDC vaccination recommendations. So the last slide on vaccine, and I purposely did slides this time because there are a lot of questions, and Robin can make the slides available as well as the recording. If somebody wants a quick look at the slides, you're welcome to do that.
And just to let everybody know, yeah, and I'll tell everybody where, or Ashley, if you can tell everybody where those things will be posted in the chat, if you don't mind.
And then as we go along, when I get to long COVID, there's an article and a podcast I was going to pop in. I'll send it to the chat so people can access that directly themselves as well. So as I mentioned, updated vaccines target recent and historical variants. It's a vaccine, it's not a booster. We can receive both flu and COVID at the same time and expect that they both will be effective. We already talked about vaccine side effects, and this is important. The federal money for free COVID vaccines went away. Most of the insurances, Medicare, Medicaid varies a little bit state by state, but Medicare, most Medicaid, and most private insurance is going to cover the COVID vaccination.
Although you might have to actually submit for it, which came up in our family. They didn't just give it to you for free. You had to pay a couple $100 up front and then submit it on the back end to insurance. So
there you go.
Yeah.
If you are uninsured or underinsured, but don't fit into one of those other categories like Medicare or Medicaid, then the current administration is going to be providing funds for those who are uninsured or underinsured. So hopefully I don't know how quickly that's going to be available. So that's the other issue, but that is the intent. And as I was saying, almost everybody should get the new COVID vaccine. So if you're previously vaccinated, you get the new formulation. At least if you just got boosted 2 months ago, you can get the new vaccine. If it was further away, don't worry about it. You want the new vaccine. If you've never had a vaccination, they're going to want you to do it as if you started from scratch. So get the vaccine and get a second dose 3 weeks later to get your immunity up as high as possible.
So can you say that again?
If you've never been vaccinated against COVID and you decide you're going to do it now, you would get a vaccination with the new vaccination. And then 3 weeks later, you would get the second dose, just like we did with the Pfizer and the Moderna in the very first place.
Oh,
the
wow.
2 doses 3 weeks apart give us your best immunity.
That is important. I have not heard that.
Yep.
Okay.
Yep.
Thank you.
If you're immunocompromised, there may be times when your medical provider wants to have you take more than 1 dose, and that would be fine. We do know that immunocompromised, especially if you're on medications that are contributing to that, do not get as good a response out of any vaccination. And so it might be something that's recommended by your provider. That would be on an individual basis. So we'll move off of this and pop into the next area. You see how I color coded everything?
Nicely done. Nicely done.
Okay, so what is long COVID? That you would think we would know that, but it's actually been pretty challenging, and it's been an international discussion. So I'm using the World Health Organization definition, which is pretty clean. So wide range of persistent, new or recurrent symptoms from COVID that are either you had with the COVID or that you got after the COVID. Initial infection, but if any of those symptoms within 3 months of an acute COVID infection, then you don't have long COVID. If it lasts longer than 3 months, and it has to last at least 2 months, so there may be some people that kind of fall into a gray zone here, then the World Health Organization considers that you have long COVID. And the reason for this is that some of the symptoms, particularly respiratory, that cough lasts a long time, and you may not have long COVID. So that's why they're giving the 3 months. There was some argument about maybe it should be like 3 weeks, and that is way too short when you look at the way the virus works. What it is not is there have been lots of reports of higher rates of other diseases since someone has had COVID and during that have come out of the pandemic. So if you look at the first couple of years of the pandemic, we are seeing higher rates of diabetes, both type 1 and type 2, other autoimmune conditions, Crohn's, some of those things. And POTS syndrome, I'm going to talk about POTS very briefly. So POTS is paroxysmal orthostatic tachycardic syndrome. So what it is a discrete autonomic nervous system issue where you, from either a sitting or reclining position, stand up and you will get tachycardic, you may faint, you may have dizziness, and your body is not doing its normal auto regulation of your heart rate when you change positions. So that's kind of the simplest way to call it. It is a discrete entity that has specific criteria for definition that I'm not going to go into. But what's happening is some people are, and POTS has increased over the last couple of years, the true diagnosis of it. But some people are calling their brain fog or some of their other cardiac symptoms POTS, and some providers are calling it POTS as well. And because POTS is a discrete syndrome, we want to be sure that that gets dealt with by the neurologist or cardiologist who you see for your tachycardia or whoever is identifying this constellation. And it's been around for a long time. It may be triggered, as many things are, by that viral insult. But it is a discrete entity. So I just wanted to make that clear, because this brain fog and some of the other things seems to be people are just dumping everything into long COVID. And the same thing with some of the autoimmune conditions. It's interesting about diabetes. So type 1 diabetes has had a known association with a post-viral syndrome trigger, but type 2 diabetes, which we typically get, may have a family history and we may get as we age, has not so much, but we've seen increases in both of them during COVID. So there's a lot of work being done on the endocrinology side with this. We just want to be sure that these things are looked at as separate from long COVID. So I'm going to show you the symptoms that are the huge range. I mean, any single symptom could be part of long COVID, but there's some very interesting international literature that was published last year that I want to show you how to sort of more cleanly look at what long COVID may be and who gets it and so on. So with the data that we have, and there have been lots of small studies published, any age can get long COVID. We're seeing it more in females than males, seeing it more in people that were hospitalized, and especially in people that were sick enough to be in the intensive care unit, those who were not vaccinated. And there's been some very interesting work looking at time frames when the vaccinations first came available and who was able to get vaccinated and who chose not to, underlying health conditions, and then the standard health inequities that I talked about at the beginning. So if you want to move to the next slide, and I will let the noisy dog out. Sorry. This is the study I was mentioning, and it comes from the Institute for Health Metrics and Evaluation. And you heard us talking about this group in the early days of COVID, if you were on those calls. IHME is situated in the University of Washington in Seattle, and is a research arm that had initially just been capturing a lot of data on COVID rates, both infection rates and deaths and so on. They do a lot of work on the global burden of disease, so across the world, and they have a consortium that they work with for this. And this particular study was one looking at long COVID. So what they did, it's a very interesting study and the way they did it. And it does have its limitations, but it's probably our best sense of what long COVID looks like across the world. And so they were able to pool data on these 3 different symptom clusters. And so what they came up with, it clearly anywhere on the body, and you'll see there's not skin, there's not gastrointestinal symptoms in here, but the 3 key areas that seem to last the most were persistent fatigue plus pain, musculoskeletal pain, and mood swings. So that's one group. Cognitive problems, that would be the brain fog and memory concerns, and then ongoing or chronic respiratory issues. So those are the 3 clusters. That obviously does not capture every single person with every single symptom, but it does pick up the 3 sort of major groups. We know that there are 2 big sets of people who have long-term symptoms, and one of them is the group that we heard the most about originally, the cardiovascular and pulmonary injury, chronic renal failure from being incredibly sick. And those people have complications that are going to be with them for the rest of their lives because there's been organ damage. And that group is separate. They have long COVID response, but it's separate from this other group of long COVID. So it's not saying that initial group with organ injury and so on isn't important, but saying that we're looking at a different group. And this is the group of people that had COVID infection and that didn't come out of it with a major organ event, but has all these kind of chronic symptoms.
We do have a couple of things in the chat when you take a breath.
Sure. The respiratory group, I will say, probably is a crossover between, I don't know if that's one of the things in the chat, between the original injury group and the long COVID group.
So the question is, what percentage of people who got long COVID received all COVID vaccines versus those who received no COVID vaccines? Do we know what the percentage of long COVID is? It's not, might not be sorted in the data yet.
Do not have that in this data, right?
Yeah.
I will comment on that at the end with some prevention information, but it's not in this data. So what they have, the value of this is that they had data for 1.2 million individuals across 22 countries, including the US. They used 2 United States major medical record databases. It is the first 2 years of COVID. And so 2020, obviously, we did not have vaccinations till the end of the year, and 2021 we did. So you will see that some of the data is pre-vaccination. And it's pooled data from 54 studies. The thing that is really good is that they were symptomatic COVID patients. They had a few that were asymptomatic. They took them out because they wanted to really focus in on the ones that were symptomatic to begin with. So we're not answering anything about if you were COVID positive but asymptomatic with this study. The proportion of people, individuals. The beauty of this was individual data and their self-reported symptoms. So it's not waiting for a physician or a nurse practitioner or somebody to bless them and say they have long COVID. With one or more of the 3 self-reported symptom clusters that I mentioned, was 6.2% of their study population. So some of those would have had vaccinations, some of them would not have. In the fatigue cluster, out of that 6.2%, 3.2% were in that group. 3.7% were in the respiratory group and 2.8% were in the cognitive group. So the respiratory clearly had more. And again, this may be that crossover between lung injury and long COVID on another basis.
And so just to state that in another way for us normal people that are not focusing on the statistics necessarily, is it looks like if you had respiratory symptoms, you were a bit more likely to get long COVID, or the percentage of people?
No, just the percentage of those reporting that they had long COVID. What had a higher percentage slightly higher percentage in the respiratory group than in the fatigue cluster. But you will see the blue numbers that I put in there. 38% of the long COVID group had 2 or 3 clusters, so not just one.
Yeah.
And I'll show you a graph that it separates out the male and female. It's really quite interesting to see the differences between male and female. But that's what those blue numbers are. So of the long COVID group, 51. So the smaller percentages are the overall population. The blue ones are the long COVID group. So in the long COVID group, 51% complained of symptoms that would put them in the fatigue cluster, 60% respiratory, and 35% cognitive. You see that adds up to more than 100 because of the overlap of some people having multiple symptoms.
And I just want to jump in here because we've had some debate in the chat about whether or not you need 2 vaccinations. And it looks like that the CDC's recent guidelines, which are in the chat, is that if you're over 12, you only need 1 dose of Moderna or Pfizer if you're unvaccinated, just to clear that up. People have been researching that, and the table is in the chat. So anyway, just wanted to make sure people saw that. I don't know if that's updated, but I can't access it.
Yeah, I don't know, because I just grabbed those recommendations from the CDC yesterday. So for unvaccinated.
Novavax requires 2 doses. Thanks, Julie.
Okay. So that's correct for the Novavax.
Yeah.
Which is what I was talking about. So the average months of long COVID disease, it's clear that long COVID can resolve on its own. The average length of duration, if people were in this category because they had more severe disease, so they were hospitalized with COVID, was 9 months, and it was 4 months if you had the milder non-hospitalized form of COVID. Remember, this is on top of the, at least 2 months of symptoms. So, you've got
a long
3
time.
months. Yeah. 3 months of COVID, which is why it feels like it's forever. So it's a full year at least for people who were severe with their hospitalization, and at least 15% of people with long COVID are having it for 12 months or longer. Okay. So next slide. This is the picture, which I think is helpful, where you can see that women more common than men, certainly older, more common than younger. And the constellation of more than 1 symptom cluster significantly higher for women than for men. The fatigue and respiratory combination, more common for women than men. And the fatigue, cognitive, and respiratory fairly infrequent for younger people and men compared to women. So it's nice because it shows how these overlap and how you might have higher percentages of people reporting many symptoms by these groups. And again, this is not negating those with chronic GI issues or other things. It just was a nice way for them to categorize this wide range of data. And loss of taste and so on. All of those things clearly are in there. However, not the way they were able to capture this data.
Mm-hmm.
So if you go to the next slide,
Mm-hmm.
we are, and
okay.
The one thing I did want to say just before, well, actually, let's see if there's questions I can't answer.
So there are a lot of questions. So I'll go ahead and tee them up. But before I get to the questions, I just want to also let people know, because we have 9 minutes left, that if you have not yet seen, we are launching our X Center on Transgender Health tomorrow night. And Ashley's gonna, she just put that in the chat. You'll see that our lowest price ticket is $10 if you do not want CEs. And I just want to let you know that if $10 is too much, we don't want money to be a barrier in terms of signing up for that. So if you need a free ticket, just please send an email for the non-CE tickets. We're making those available free if that's something that you need. And so we're super excited about this Transgender X Center. It's the first of several X Centers that we're going to do. And so click the link to hopefully see you tomorrow night for the live panel discussion if you want to do that. And then the sessions will be available on demand after that for 2 years. They are, if you do need BCPA CEs, they've qualified for ethics and JEDI, which is justice, education, disability, and access, I think, ones. Okay, so
and share it with everybody you know.
Yeah, thanks, Beth. So let's get back to some of the questions we have in the chat here. So there's a good one to dispel. Can people get long COVID from any of the COVID vaccines, Dale? Can you address that?
No. None of the COVID vaccines have live virus. So it takes live virus to get COVID infection, and you have to have COVID infection to get long COVID. The vaccinations, with all the data that's available, will decrease your risk of long COVID. And so let me just mention a couple of things here about prevention, because the prevention is what keeps you from getting long COVID. Don't get COVID. And the other thing is, getting COVID and getting COVID again, that does not protect you from having long COVID. You have a risk of getting long COVID anytime you have a COVID infection. That's the current data. So anything that avoids getting COVID or decreases your severity of COVID is going to help you prevent long COVID. And I'm hearing in the general population, overhearing conversations of people saying, COVID's just going to be like a cold, I'm not going to worry about it. And they're not thinking about long COVID. So and I guess since this data suggests long COVID is probably less likely if you have mild disease, that's a little bit reassuring, but I don't want somebody else to give me COVID and get long COVID. So vaccination is our primary way of avoiding long COVID, because it's our primary way of, first of all, we will decrease our risk of infection. We will not be able to tell you what the effectiveness for prevention of the COVID infection is with the Novavax, that newer vaccine, until we see months go by to see what it really works, how it really works in a real population. there will be a certain percentage of prevention where, hopefully it's 65, 75%. That would be fabulous. We will definitely see lower risks of hospital admissions, ICU admissions, and deaths if you get a current vaccine. Masking, I saw some comments about masking in the chat. Yes, mask when you're in public. Avoid going into large public places any more than you have to.
How often to change a mask?
Change
the
mask. You should be putting on a fresh mask every time you go out there. So not everybody does that. Wearing a used mask is going to be better than wearing no mask. So you want to try to get one that's really well fitting. So I know there's a lot of concern about whether what type of mask and so on. If you're very worried about it, then one of the KN95s, or I've seen people wearing N95s around as well, but the KN95 or a surgical mask. Yeah. The other thing is there are a fair number of research studies that are being carried out by the NIH. If you or someone has long COVID and is interested in participating in a research study, please look up the NIH website, just nih.org, and you will be able to see the different ones that they're doing and see if you would qualify and if you want to sign up for it. There are suggestions that taking Paxlovid at the beginning of your infection is effective in decreasing the risk of long COVID, again, by decreasing severity of the disease. There are other medications that are oral that we don't really have in the US that we're using in the United Kingdom and other places that are similar to Paxlovid. They're antivirals that are oral. And then there are studies that are happening now about potentially doing disease modulation for admitted patients as well. Maybe being more aggressive about treating with these antivirals when people are inpatient, even if they're not in the ICU, for instance. So those are all research right now, because we don't know if that makes a difference in prevention of long COVID, or chronic organ injury. But there's a lot of research that's happening right now. So I did want to talk about that because the prevention is what we want to do to decrease our chances of that. What else?
So, yeah, I mean, we have a couple more, and, I feel like we could probably go on quite a bit more.
Yeah.
So another perspective from board member Michael Wood is asking about the difference in the US recommendations versus Europe, as Europe is only recommending vaccination for those over 50 or over 65 with risk factors. So there's a response from Chris in the chat about how we often differ in the recommendations. And I guess, I don't know if you want to address that before we end today.
Yeah, we do often differ from the European recommendations. The crux of recommending vaccinations for everyone really has to do with avoiding long COVID for younger people and avoiding transfer of a virus from a younger person to an older person or an immunosuppressed person. So that's been fairly typical for the US population when it comes to vaccination recommendations, is to really try to, keep the virus out of the population in whatever way you can. So I think that young adults will decide whether they want the vaccination or not, just like they do with the flu. Not every young adult gets a flu vaccine. when it comes to being around your grandparents or other friends or family members who are older, you not being vaccinated may not get you access to those people, depending on what that elderly person wants to do with their life. My mother was like that. She would not let anyone unvaccinated come visit her, in her later years, because she was not interested in getting sick. So I think that we all have to figure that one out for ourselves. But if you're in a high-risk group, it's taking a big risk to not vaccinate, and everybody will again make their own choice for that.
So there are more questions and comments in the chat, but we are at our time for the day. But please join us next month, which will be November 13th. We will give some opportunity to answer your questions about COVID, pairing with another topic. And we're still working on our speaker, but we will be holding our next conversation November 13th. And I just want to thank Dale for your deep dive into the research and giving us so much to think about and talk about today. We're very, very grateful for your ongoing work on this and volunteering your time to make sure that we are up to date and kept informed. Thanks, Dale.
Thank you, Dale.
Sure. Thank you. And I think it's just a fight we're going to have to keep up and try to protect ourselves and our loved ones. That's where we are.
Yeah, thanks so much. Stay safe out there. And we will hopefully see you tomorrow at X Center launch, if you can make it, and see you at another event. Take care. Bye.
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 Thank you.